I'm going to talk about this case study throughout my presentation, and I'll just introduce you to John. John isn't his real name, but he's a fellow I took care of within the last few years who was an 89-year-old male retired football coach who lived in a memory care assisted living facility, who was tended to be combative and aggressive periodically. The facility threatened to discharge him if his behavior continued. Typical scenario in practice, and you may be on the receiving end of these calls as a participant today as a provider, or you may be a staff person reaching out to the provider when you have a situation with a resident like John. So I would have received a call from the memory care facility requesting a medication for John because John was trying to elope every morning after breakfast and leave the facility, and he would become combative with staff who tried to redirect him. I also received a call from his son, who is concerned that if something isn't done, his father will be discharged, and his father can't live alone because he needs 24-hour supervision, although he's really quite healthy for his age. He was always exercised daily, and he was an avid golfer into his mid-80s, a very physically active and fit fellow physically. So as I go through my presentation, as Julie said, please type in comments that come to mind regarding how staff might manage John's behavior and or how you might address it. And then I'll bring up John throughout the presentation. So what is agitation? Agitation is a behavioral syndrome that's characterized by increased motor activity, which is often undirected, restlessness, just a feeling of can't sit still, aggressiveness, as in John's case, and often emotional distress. There's a prevalence of about 30% overall in dementia patients of agitation, and it's the third most common neuropsychiatric symptom in this group of patients with dementia, following apathy and depression. And agitation is prevalent in about 80% of residents in nursing homes who have dementia. And as I said, that's a group of patients or residents I've targeted in my presentation today. I'm sure those of you who work in long-term care, skilled nursing facilities are familiar with the term BPSD, behavioral and psychological symptoms of dementia. And this is a range of disturbances, as I said, that includes agitation, aggression, depression, apathy. These symptoms affect almost all of residents with dementia at some point in their lives, 97% of community dwelling patients. And its significance is that it has a huge impact on their prognosis, whether they require institutionalization, placement in a memory care unit or skilled nursing facility. And as we all know, caregiver well-being. It's very stressful to care for individuals with these behavioral and psychological symptoms. What causes agitation? It might give one insight into working with families if you can explain a little bit about what causes it. And one of the causes, because this is one of the symptoms that I mentioned, one of the causes is found at postmortem exam, at autopsy, or through functional scanning, that we now know that this is triggered by frontal lobe dysfunction. And there's also a huge component of anxiety often in dementia, and this most likely amplifies agitation. And it's possibly a risk factor for the development of agitation. And I can think of many, many elderly patients with early cognitive decline who I had seen as an outpatient in my practice, who they're presenting symptom, often depression and often anxiety. And this is probably a marker, a precursor to this is someone who might develop agitation. I've found it helpful over the years because of the significant amount of stress that caregivers experience working with residents like John, to use the analogy that when trying to educate them about the individual's disease, that it truly is, in quotes, a situation where they have brain damage, because that often decreases some of the stress of family members and other caregivers. And you might use this with staff in education to try to take off the onus that the resident isn't doing this on purpose to cause irritation in the caregiver. Here are some examples of agitated behaviors, and we're going to talk about how to evaluate agitation. And it's really important to label the exact behavior you're seeing when you're communicating with family or with a provider about what the agitation behaviors are. And I'm sure you can all recall examples of some of these various behaviors, and they range from shadowing a caregiver, frequent arguing or complaining, becoming easily upset. And I'll get back to that. Repetitive questions, asking the same question over and over again. Where is my wife? When can I go home? That kind of thing. Pacing, hoarding, rejection of care or resistance to care, particularly with ADLs, with bathing and dressing. Restlessness, just that feeling of kind of ants in the pants, can't sit still. Inappropriate crying out or screaming. Verbal or physical aggression, which was the situation in John's case. Sleep disturbances, wandering, and inappropriate sexual behavior. Going back up to becoming easily upset, there's a phrase used in dementia care called a catastrophic reaction. And I thought this was so interesting as a fellow in geriatrics. And I think it's one of the key aspects of being a caregiver, that these patients can be quite unpredictable, that you might be assisting someone in dressing or using the toilet, and just out of the blue, they just sort of pitch a fit, and as if they were a toddler. And that adds to the stress of caregiving and the difficulty often with managing patients with dementia who have a tendency towards agitation, that this can sort of turn on a dime. And it's very important that staff and family be prepared for that and have a plan for what they'll do in that case. I'm going to bring this up several times today, but these are the APA, the American Psychiatric Association, recommendations for non-emergent antipsychotic use. And I'm going to talk about the non-pharmacologic options that we always want to exhaust first before thinking about prescribing a medication. So I'm going to bring this up again. But first is to always assess for pain and treat as needed. It's not uncommon for someone who has dementia, might have aphasia, expressive aphasia, that they're crying out because they have a painful joint. And if you prescribe over-the-counter pain medications such as acetaminophen on a scheduled basis for a few days, this may decrease some of that behavior. Second point is, again, to exhaust all non-pharmacologic options and use when symptoms are severe, dangerous, or cause significant distress for the patient. Those would be recommendations for antipsychotic use on an ongoing basis in a dementia patient. And they recommend starting with a low dose and discontinuing therapy for severe adverse side effects or lack of improvement at 4 weeks. And even if the medication is effective, you should always attempt a dose reduction, a tapering at 4 months, not consider and reassess it. And individual might very well warrant continuing it, but it shouldn't become an autopilot medication. And if you're in the skilled care world, you know about pharmacy reviews and requests for dose reduction that providers will be sent. So how do we assess agitation? As I said, agitation is one of the behaviors and psychological symptoms of dementia, and it's a diagnosis of exclusion. We always want to look for any other cause that we can control or improve or eliminate. And again, always check for causes of discomfort that could be a cause of agitation that the resident is not able to articulate, such as pain. They could be in pain, assess whether they might be hungry or thirsty, and they're not able to express that. They may need to void. An elderly man with a BPH, an enlarged prostate, may have some urinary retention, have difficulty voiding, and may need to be taken to the bathroom and assess how they're urinating, and to make them less uncomfortable. And sometimes constipation will make a dementia patient uncomfortable and they're not able to express it, so they become restless. And another very key factor of assessing agitation, and this would fall more to the provider side, that I'm sort of wearing two hats here as a medical director and as a retired provider, thinking about, you would contact the provider, but staff should always keep in mind, are there any medications that might be causing side effects that are causing agitation? And this is the term for restlessness, which is a symptom, as I noted, of agitation that can be caused by medication side effect. The term is akathisia. And so it's really important that you think of this before you ask for another medication or consider prescribing one, is first to review the resident's medication list. And I think those of you who've been in this field for a number of years probably recall, before we had the more what's called the atypical antipsychotics, the old-fashioned first generation antipsychotics such as Thorazine, very high incidence of side effects. But all antipsychotics can cause akathisia, so that has to be considered if they're already on one of these medications. But the other items on this list below antipsychotics are other very commonly used medications in the elderly that could cause restlessness or other symptoms that you would term agitation. And those include antiemetics, medications used for vertigo. Think about the number of times you might order an elderly person meclizine for labyrinthitis for vertigo, and this can cause significant side effects, including akathisia. And both in the antidepressant medications, tricyclics, one of our old tried and true classes, which are used much less frequently now, and SSRIs, selective serotonin reuptake inhibitors, can cause this side effect. Calcium channel blockers used for blood pressure and rhythm and rate control can cause the symptoms, and anesthesia sedatives. And I think this is an important one to consider if you've sent a resident off for some procedure that involved even conscious sedation, a dental procedure, a dental extraction, or colonoscopy, or perhaps an outpatient biopsy. If they come back to the facility and their behavior has changed, you may need to be patient and wait a few days for that to clear their system as a side effect. Another key point looking at medications is to review the medication list and consider a trial off or a dose reduction of all these categories of medications I've just discussed, and avoid the prescribing cascade. That's what we call it when we prescribe a medication to treat the side effects of another without adding, rather than eliminating or reducing the dose of some of these possible culprits. And the person with akathisia, we think that they probably experience just a sense of unease or inner restlessness that often involves their lower extremities. And that probably leads to that can't sit still kind of behavior and a compulsion to move. And they may cross and uncross their legs, shift from one foot to another. They may appear to be fidgeting, persistently fidgeting. I want to just touch on staff training and education in agitation assessment from the standpoint of as a medical director or a provider. And those of you who are staff members at facilities, you can look to your medical director or use some of these tips from the standpoint of a medical director, that very likely you would have participation in quality improvement products projects such as antipsychotic reduction. And also the medical director often and should serve a role model function with their interacting with their own residents and with staff who care for them, and document the stepwise approach that I'm going to describe to assessing and treating agitation. And an analogy I've liked to use over the years in staff training is to think about if we had someone who had an elevated blood pressure, we wouldn't diagnose hypertension and treat them unless it was dangerously high without obtaining more data, without recording several blood pressures and charting them, and trying non-pharmacologic management. Again, if they didn't have dangerously high blood pressure, we would recommend salt reduction and smoking cessation and exercise, and then document over a period of time whether that was effective or not before we'd prescribe medication. So I think that's a good concrete way to educate staff about the importance of documenting specifically what behaviors they're noting in a resident that they deem agitated. And as a staff provider, I've received many calls over the years asking for a medication. A call in the old days, we used to receive a fax. John is agitated. He's attempting to elope every morning after breakfast. Can we have a medication for him to treat this symptom? And it's really a challenge when as a provider, these are some tips that I'll share with you of what your response can be to staff members who contact you. I would ask for the necessary clinical information. And I would ask, what specific behaviors are you seeing that represent agitation? When do they occur? I'm thinking of John, his morning pattern. That would be his pattern of the day and the situation. And I would ask them to send documentation to review. And I'm going to talk a little bit about the requirements in memory care or basic care in North Dakota versus skilled care. And of course, the documentation guidelines vary significantly. But it is a challenge as a provider to, when a facility staff or their leadership don't have a good understanding or background experience in agitation assessment and management. But I've found that with some gentle prodding and a few back and forth, when it's not an emergency situation, asking these questions can prompt them to jot down and to start charting some of these patterns. And I think it's educational on the other end too. And it's really important to involve family as the provider so that they learn that the first response isn't to call for a medication, that they hopefully develop some of these problem-solving skills. And they're probably that have the most contact with the resident to help determine if there might be a pattern, like John's son. Here's a commonly used charting document, the Cohen-Mansfield Agitation Inventory. And you can see it lists, it breaks down into categories: physical, aggressive or non-aggressive, verbal, aggressive or non-aggressive. And it asks the staff member to circle how frequently these things happen. And if this is done over a period of even 2 or 3 days, it's very, very helpful to help staff strategize non-pharmacologic, and you as the provider to consider pharmacologic management. And each facility might have a different tool. And as I said, documentation guidelines, of course, differ greatly between an assisted living facility, and that's state dependent, and also a skilled care facility. But I think it's just crucial, even if it isn't required to document in a memory care unit on a periodic basis or a set interval, that it's crucial that staff communicate throughout the facility what works best for each individual when they have a catastrophic reaction, or John wants to leave the building and becomes combative after breakfast, and communicate that so that if it happens on the night shift, that people are prepared and have some kind of a tool to pull out and read, oh, this is what works best with this resident, with this individual. So this is one of our quiz questions. These are the non-pharmacologic interventions that have been proven to work in dementia residents with agitation. And they are music therapy, outdoor activities, massage, and modification of the IADLs. And because my talk is limited to individuals who are residing in a long-term care facility, I'm assuming that these duties have already been taken over for them. And these would be the above the basic activities of daily living, such as shopping, housekeeping, managing a checkbook, preparing food, driving. And we're just going to assume that these have already been taken over for them by the family and or caregivers at their facility. And these measures have, as I said, research has shown are proven to work. However, they often are only effective at the time of the intervention. So, for example, one outdoor walk a week is not necessarily going to take away John's agitation throughout the week, or one music therapy session, but they're certainly helpful. And again, this would be what I would want each resident's care plan or communication with staff and family to know what works best for them. And communicate that with each other. Here's a little more detail on those interventions. Again, it's always important, as the APA recommendations are, try these strategies first and continue them even if medications are used. So if you have a resident who responds to their favorite music, that they find it calming, continue to do that when they have a blip in their agitation or behaviors. Don't discount that. Now we have medication, we don't have to worry about that. This still needs to be part of the toolbox, or the things that are available and communicated to everybody who works with that individual. And as I said, non-pharmacologic interventions often don't have lasting effects, but they may improve immediate agitation. And an example of this would be some of the examples: take a walk with a resident, play their favorite music, try a hand massage. I will caution you though, these certainly need to be individualized. I've had a number of, always in my recollection, male patients who have had inappropriate sexual advances as one of their behaviors. And it probably wouldn't be appropriate to recommend a hand massage be tried in an individual like that. So that's even more important to communicate to other staff who might be filling in with the resident in providing their care. Here are some other non-pharmacologic interventions, and this may seem pretty basic to those of you who work in the field, but these are the basic principles provided by the Alzheimer's Association. And I found that when I've received calls over the years requesting medications, that I could either delay or deflect a number of the requests by asking a few questions, and also observing staff or family members who might bring the individual to the office for an appointment, or if I was going to the facility to see residents, to see how staff responds to residents' behavior. And as I said, these seem pretty basic, but I think it warrants reviewing them. And these are all just in general basic good tips for dementia care. Create a calm environment. Too much stimulation, the television in the background, noise, glare on a shiny surface from a sun coming in the window might be misinterpreted by some residents as a fire. If they have illusions or delusions. So create a calm environment. The second is to simplify tasks and routines. Always only give one step of a command or a recommendation before you move on. Don't say, well, let's get your shoes and your raincoat and button up and go out for a walk. Start with, let's get your shoes. And again, that seems pretty basic, but too many commands rather than a simple step-by-step is very distressing to an individual with dementia, and particularly if they have one of the BPSD symptoms such as anxiety or become easily agitated. This seems really basic, but arguing with residents, I've still, even towards the end of my practicing time, seen in times where staff, I'm sure well-intentioned, but your immediate response is to argue with the resident or try to reorient them to reality. And this often becomes confrontational and leads to agitation. For example, an individual who says, I want to see my mother, or where's my wife? Rather than point out that that individual is dead, it's important to acknowledge the emotion that they miss this individual. Your mother is a wonderful person. I would like to see her too. Somehow deflect it, acknowledge their concern or their desire, but not confront them with that individual is no longer living. Redirection is something that is always a good idea. And as I said, try to take their mind off that they want to leave the building, or that they're waiting for someone who's not going to be coming to visit them. And again, be supportive and patient and respond to the emotion and not to the behavior. It's important that the residents have adequate rest between stimulating events, that they're not overscheduled with, oh, you want to come to bingo, and now we're going to do lunch, and then we have a music program. Some residents, again, individualizing care, they may like to be on the go all day, but others might find it like stimulation overload. And again, acknowledge their request and respond to it. And most important, look for reasons behind each behavior and go through that mental checklist again. Could they be in pain? Could they be hungry or thirsty? Could they be sad? Could they have a need to use the bathroom? Here are some non-pharmacologic interventions that have been tried over the years that have not proven by research to have cause lasting improvement in agitation. And I've seen some fads come and go in dementia care over the years. And again, individualizing and person-centered care is so key here. And some of the things that have not been proven to work are bright light therapy, aromatherapy, and there was a trend a number of years ago called snoozalin therapy, or creating a snoozalin room. Some of you might be familiar with these, or you might still have one available in your facility. And it was a room that was created, I believe, in the Netherlands. And it was a space to take an individual with cognitive difficulty and introduce them to various lights and colors and scents and tastes, and that some people found that calming. And again, I would say if John, the patient we're talking about, in my case study, is calm by sitting in an environment like this, then please share that with other staff members. But as a general rule, this has not been found to be very effective. And as I said, I encourage staff to determine which interventions work best for their resident, for each resident, and to share that information through the resident's care plan. Dementia is not a one-size-fits-all.
Is the difference between delirium and agitation loss of attention span with the former?
Delirium is a waxing and waning change in the level of consciousness. It can be either acute or chronic. As far as the difference in attention span, I would say that it's much more common that an individual with delirium, and certainly delirium is a very common overlay on top of residents with dementia. And as I said, that's outside of the scope of my remarks per se, but that individuals with dementia and behaviors often have a decreased attention span also. But one of the hallmarks of delirium is a shortened attention span. This is a very good question. Given the time of behaviors, I wonder what John's prior routine was. Did he golf at that time? Did he coach at that time? If so, perhaps some sort of physical activity at that time would help redirect John and minimize his behaviors. Stephanie, you're right on. What is your field? Can you chat or unmute and tell me what your role is in a facility?
I am the program manager and clinical nurse specialist for the Acute Care for Elders, or ACE team at UW Health in Madison, Wisconsin.
Perfect, perfect. Well, you are right on, because what I did was I chatted with John's son, and he told me that John had a very active lifestyle prior to moving, and that he was in the habit of going to the Y every morning after breakfast. So we decided that I communicated with staff at the memory care facility, very responsive staff, and John also worked with the staff. And when they were able, they tried to free up a staff member after breakfast who could take John to the workout facility room and support his exercise when he became agitated or aggressive after breakfast, because that was his pattern. That didn't solve all the cases, but that was a very, very, you're right on when you thought about that, is to find out what his past history was. And the other thing I did was and often residents, of course, who come to assisted living or skilled facility, we assume their care, and we didn't take care of them for years and years, and we often don't have their outpatient records to review. And I asked his son whether he'd ever taken a cognitive support medication, such as brand name Aricept, one of the cholinesterase inhibitors, or an NDMA, another class of dementia medications, because that's one thing to think about trying from a pharmacologic approach. Is these often are somewhat helpful for behaviors and agitation. And talking with John's son, and John had moved from another community to be closer to his son, John said, yes, we did try those medications in several years prior, but unfortunately he didn't tolerate them due to GI side effects. And I'm going to comment on that in my discussion about pharmacologic intervention. Just move to the next slide here. Let's see, it looks like there we go. So as I mentioned, in quotes, cognitive enhancers, and these are the two main classes, are cholinesterase inhibitor, and the two main classes in that category are brand names Aricept or Exelon, donepezil or ribostigmine, or the non-methyl D-aspartate antagonists, NDMA antagonists, memantine or Namenda is the most common. And again, as I said, if John's son had not told me that he'd tried them in the past and he didn't tolerate them, I might have suggested considering a trial starting with probably donepezil. With pharmacologic interventions, the recommendations are to target the symptoms, start low and go slow, avoid polypharmacy, which in the geriatric world is, there's not a set definition, but anytime you get have an individual who's on 5, some people consider 5 medications or 9 or more prescription medicines, that constitutes polypharmacy, which increases the risk of interaction and drug side effect. And I described the prescribing cascade you want to avoid, and that's adding a new medication to treat the side effects of a medication that they're already taking, rather than looking at tapering that dose. And it's always a good idea to only change one medication at a time. Obviously, so you can determine what worked. If you taper one medication, try that for a period of time before you consider adding another medication. So you want to try to be able to determine which medication, what your changes are, what effect they have. Always avoid benzodiazepine. And I would say the most common request that I would get from a facility, usually a memory care facility, is for something to use PRN acutely. And of course, in the long-term care world, that's very frowned upon, that it tends to be, it's easier to prescribe in an assisted living or a basic care, memory care facility because the regulations are much less stringent. And it's real easy to fall into the pattern of staff saying, oh, he needs an Ativan or even a Xanax when he gets into that behavior, and the family buys into that, or they trust the staff. That can be a hard habit to break. And you also want to set realistic expectations with family and staff that prescribing a medication for behaviors is not necessarily going to eliminate all of them, and that they understand that it's not a magic bullet. Another important aspect of pharmacologic intervention is these are all off-label uses, meaning that if you read the package insert for medications that I'm going to discuss, they are not indicate, they do not have the indications listed for behaviors of dementia, the BPSD. And it's important, in my opinion, it's your responsibility as a provider to obtain informed consent and document it in your clinical chart from the medical decision maker, whoever's that person's medical power of attorney. And the conventional and the newer atypical antipsychotics both contain black box warnings regarding increased mortality in elderly dementia patients due to cardiovascular and infectious events. You always have to weigh the risk versus benefit. In John's case, if the staff or facility administration is threatening to discharge him if they can't manage his behaviors, that's a real risk that has to be. But it was important to me to talk with his son and make sure that he understood this risk of using any medications for him. And then the question is, which medications do you start with? And again, we go back to the APA, the Psychiatric Association's recommendations. And again, the key is to use when symptoms are severe, dangerous, or seem to cause significant distress for the patient. Someone who's constantly on the go and fidgeting and can't sit still, is that, do you and staff and family perceive that as distressing to them or not? And that's kind of the guidelines for prescribing. And generally, because of the high incidence of depression, you could see depression is, from earlier in my slides, one of the most common biological and psychological symptoms of dementia. I often will start with an SSRI, with an antidepressant, and start low and slow and go slow. One study, and this is one of the pitfalls of antipsychotics are they tend to increase fall risk because they can cause orthostatic hypotension. And one study in the compendium of family medicine that I use as one of my references was citalopram, one of the SSRI antidepressants, compared to two of the atypical antipsychotics, olanzapine and quetiapine, cause less falls, less orthostatic hypotension, and hospitalization. So it's true. You want to, and I would always tend to, again, talk with family about, have they been on an antidepressant in the past? Or are they currently on one, which is not uncommon? And I would start low and go slow. I'd probably pick one of the class, because the class was reviewed as all the SSRIs. I might pick citalopram, 10 milligrams daily, and be mindful as a caveat in geriatrics that it's not unusual for elderly individuals to develop a low sodium on an SSRI. So you want to develop a pseudo SIADH, and you want to be cautious and be not that you have to check their sodium when you start it, but I would look at their previous labs and see if they tend to run a lower sodium. Just keep that in mind, and if if they develop symptoms that might warrant lab work. And as far as which antibiotic or antipsychotic rather to choose, I again would start low and go slow. I might start with risperidone, 0.25 or 0.5 milligrams per day, depending on if it's a 100-pound elderly lady or John who weighed over 200 pounds, big strapping guy. There's one other medication that was studied in the literature, and it's currently indicated. The indication is for pseudobulbar palsy, and it's called Nudexa. And it's recommended for the pseudobulbar effect, where someone cries inappropriately, but it has been used for aggression or agitation and dementia. I personally wouldn't prescribe this without experience with it. And this would be, if you're exhausted all your other options as far as non-pharmacologic and the SSRI class, if appropriate, and the atypical antipsychotics that I mentioned, I would probably consult a geriatric psychiatrist and put your heads together and get a little more input before I try that particular class of medication. And remember, you need to document your rationale for using these medications. And this is particularly important to assist other providers who may cover for you on call. And in the nursing home environment, of course, you have to have a diagnosis for every, very clearly documented for every medication, and particularly for treating dementia-related behaviors. Getting back to John's case, I'm so glad that in the chat box, I was guided to find out more about his past life and to help the staff and his son recognize that that's a really good non-pharmacologic intervention when he became agitated and tried to leave the building after breakfast, that's the time to try to take him for a walk, to do something physical with him. It could even be just maybe 5 or 10 minutes of doing push-ups or something in the lounge, but just to make sure that everybody knows to have that in hand or in his toolbox to care for John. As I said, realistic expectations. This was not a cure-all for John's behavior, and he also had a tendency to be rather impulsive and unpredictable with his physical aggressiveness. And he was a big man who could physically intimidate staff or other residents. So after obtaining informed consent and discussing the risk versus benefit with his son, I started him on risperidone, 0.25 milligrams at bedtime. And over a few weeks, the staff charted his behavior, used the non-pharmacologic techniques that worked for him. And he was able to stay in the facility, and his son was very grateful for my references.